Okay. So do you have any attendance form or list?
Yes, Doctor.
You do have. Okay, then please fill it in first for any of you who have not filled it in. Right, let's start our class with recitation of Surah Al-Fatiha. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin arrahmanirrahim maliki yaumiddin. Let me just close the door for a while. How are you all doing, by the way? Are you all at home? Had your breakfast? You can munch away while we do the lecture. No worries. You can go and get your coffee and tea, whatnot. Okay. Are all of you here yet, or most of you are here? How many of you? Can you? That's 129 here. And how many of you in the class? Altogether?
146. 146.
146. Okay, quite a few of you are still not here, but 20, nearly to 20. Never mind. Those who are here, please fill in the attendance, and we have the recording as well. So you please share it with the others. All right. Okay. So a bit devastated in this morning because I just received a message from my friends that one of my seniors in my school passed away, and I think it could be due to COVID because her father also passed away about a week ago. She lives in Kajang, and most probably it's COVID, but I'm a bit devastated because she was very close to me, kind of like we were in the same boarding school, kind of as Puri, and she has kids about the same age as mine. She has 3 boys and a daughter, a bit older than mine, but nevertheless we keep in touch, and I think the last time she messaged me was in PKP 1.0 when she asked me about how to like arrange a schedule for her sons to be able to study. So it really, yeah, Umi tak ada telefon dekat sini, Umi tak tahu kat mana. Tak ada telefon Umi kat sini. Okay, Umi cari tempat lain. Umi tak tahu kat bawah kot. Kita tengok telefon Umi kat bawah kot. Kat dapur ke, bilik bawah ke. Kalau ada. Yeah. So yeah, I think this is the second time that someone close to me has passed away due to COVID. The first time was the first 1.0. It was my Nakiba when I was in Japan, an Indonesian lady who was also doing her doctoral study. I guess I saw that for me, the ones that Allah took away due to whatever lah, but I think there's a hadith also saying that if one dies of a wabak epidemic, it's also considered like a jihad or something, like a jihad, like a shaheed. And it seems to me the ones that I do know who has passed away are very good people, very pious. Not pious in the sense like this senior of mine. It's not like wearing big hijab or whatnot, but she was a very kind person, like not the person who would talk about others behind their backs. The posts that she would post on Facebook would be just about her family members, about praying for his son to be a better Muslim. The last post she posted was about getting a book present from someone, and it's about missing Allah, and the title was about Merindui Allah or something, and she would write like hashtag missing you so much Allah, something like that. So really, yeah, you could see that her relationship with Allah must be very close. So yeah, a bit still not over the shock just yet. All right, so we're talking about psychotherapy and also defense mechanisms today. While I talk about the topic, if you have any questions, you can just put write in the chat, and we'll address it after the lecture. I'll try to be fast so that we can finish in about an hour, because I need to send my daughter to school, to her nursery, so that I can go on with the seminar, and then afterwards we'll start at 10:30. Yeah, the seminar. All right, so I'll just share my screen. You can all see, right?
Yes, Doctor.
Okay, introduction to psychotherapy. Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wa hlul 'uqdatam min lisani yafqahu qawli. Okay, a bit about my own story, difficult moments as a psychotherapist. There are moments when a psychotherapist just wouldn't be able to be as fluent as he or she would have been when there are some clients who seem to be difficult. For example, my own experience with adult Asperger's, especially when I couldn't because this is high functioning autism, because autism is a very wide spectrum, isn't it? So the high functioning would be very intelligent. I would have clients with a master's, a PTD position, even a bank officer, a postgraduate student, like very much intelligent people who have been successful in life. And then the lower spectrum would be a child who is doing repetitive behavior, who could not speak properly, who's robotic, couldn't function on their own. So it's a very wide spectrum. So with adult Asperger's, it's especially difficult when you're not able to connect with them. There are ones who are able to connect with you, but still they don't have insight. What I mean is connecting is that when you have had a good relationship with them, you've got the rapport, but there's still no insight, as in that this is due to my developmental disability. And that is why you are not having a good relationship with your wife. And there is no such insight as that. Like it's hard to get them to see that it's because of your inability to communicate, and that's why people don't understand, and they assume, and they become frustrated. So and it's because it's an adult and they already have a successful position, and to tell them that you have autism is very, very hard. Yeah, so it took quite a while for me to be able to gain insight with them, and to help them. Yeah, but the trend is that we are getting more high functioning autism, or even moderate functioning, at near to 40. Yeah, they come in with a lot of problems with their marriage, work, personal life, health, because they've already an increased demand in their life, and they're not able to fulfill it. Before, they could probably get away with it because the wife takes over things in their family, but now their children have grown up. The children are also demanding attention, time from them. They've gotten a good position in their career, and thus they need to present, they need to talk, they need to be assertive, and that becomes very difficult for them. And then they come in with depression, or their spouse comes in with depression, and then when we get them over to the clinic, and when we assess them and whatnot, we found that it's actually high functioning autism. So it's quite difficult in the beginning, but later as we get the more clients coming in, and I get the pattern, so I began to see to diagnose more easily than before, able to see the traits in them. Another would be a married things, situations that are difficult, such as when it does not fit in with your beliefs. Yeah, it does not fit in with your religious faith, for example, though they are also of the same religion. For example, a married lecturer who comes in admitting that she has had a love affair, sexual relationship with a student. So that got me caught with shock for a moment, but I can't express my shock with the client. So I will have to be cool. I will have to tell myself that this is a client who's coming for help. So you're not going to give your judgment. You're not going to give in to your emotions. You're just going to be neutral and let them talk and let them admit, and then they'll be talking to you, and then you'll be able to help her. So talking to myself and having to put my judgment aside is already one difficult moment, quite difficult for me to do it. But inshallah, alhamdulillah, it became easier as I began to see more clients, and began to again and again, repeatedly putting my judgments aside. It's really not easy as well. And then one more thing is when I have a borderline personality adults, even with students or with young people, it's already quite difficult, but not with all. Most of the time, I do have a good relationship with them because I tend to validate them a lot. Whatever the case is, it always needs to come in with validation. You need to be able to be on par with them. You need to be able to validate whatever experience that they've gone through. But when it comes with to be a professor who is about the same age as me, just about a few years older or younger, and it's difficult because you're trying to help them, but at the same time they're like telling you that it's not as easy as you're talking. It's not as easy as just saying it out, but I'm the one experiencing it, and you're as easy as that. You're telling me that I should be learning about this and this and this, is that kind of thing. So it's very hard to help them with some skills when they already think that when you're on the same level, when you're that it's hard. And I come to it and come to a point that, oh no, this patient again, I don't know what to do with her. I really don't know, because there are some skills that we are not taught with and we need to learn. And a lot of times we need to be an expert in some disorders or some psychotherapy for us to be able to help with people with. And borderline personality is not easy because there's a lot of transference and counter transference involved, whereby you're connecting them with the person within your family or with yourself, or the client themselves connects you with their own life. So it becomes very personalized, especially with borderline personality patients. So I'm getting you all in as to see some of the difficulties, challenges that we go through as a psychotherapist. It's not an easy task to do. It's not straightforward, and it needs a lot of skills and also I would say patience. So learning from experience, I have learned to narrow the help that I could give within my own ability, meaning that if I was not able to give more, I would have to admit that to myself that this is the full stop to what I can give. I was not able to do more, or else I would be blaming, kind of like blaming myself that why is it that I couldn't help them? Why is it that they're not improving? Why is it that things have not gotten better for them? And I would blame myself, but there's just a limit to what we can do. Yeah. So, and then it's with Allah. Even with its success, it's not me or my colleagues, but it's Allah who have given us to be the mediator. It's not because we're good, but it's because Allah wants them to recover. It's with so many other factors involved, especially from the client factor. So again, it needs reminder time and again, because there are times when you just feel down. Yeah? When I just got back from my studies, there were times when I just got awake in the middle of the night, just about to fall down my bed. And I was like, did my patient commit suicide? What happened to her? I'm looking at my phone and, like things like such as that, like still thinking about what have happened to patients who have talked about wanting to kill themselves and whatnot. So it has begun to you begin to personalize it. But Alhamdulillah, I'm able to put it aside now most of the time. I read up a lot of external resources, and that helped a lot, especially when I take up talks, then I would have to read up on this disease, on this illness, on this situation. And that helped a lot with my patients. Build rapport, it definitely helps. Yes, I said just now, when we are able to be on par with them, then the intervention that we're giving will be much easier. Validate and hold back your judgment. As I said before, genuinely try to help, because when we're genuine, people would see that we really want to help them. They could see it from the words we say, from our body language. So they see that we're really trying to help them, and that really helps with the intervention. Include spiritual elements in therapy if they're suitable. If not, I would usually leave it later or not touch it at all, because this is actually very sensitive, and it's not something that is our responsibility or our role. Our role is to get them back on their feet, and later on they will be able to get hidayah, they will be able to get more guidance when they're already recovered from their illness. So I would tell myself that the first thing is to get them on their feet, to be able to be a better, responsible mother, father, sister, student, employer, to be back on their feet. That is already da'wah, to get them back and recovered. But if there is a strong foundation within them, many times I would touch on some of the spiritual elements, but it depends on case by case. Ask Allah for help. I can feel His presence when He grants my prayers. Sometimes when it's very difficult and when the patient is having very severe illness, I would really make dua for them, and especially mention their names in front of Allah, because there's no other people who can help. Okay? It's just with His willpower who can help them to recover. So I see miracles in this, because one of the most answered prayers is when you ask prayers about your friends or about people who don't know that you are asking Allah for that. Then malaikat, the angels, are also praying for you. At the same time, Allah will, inshallah, we believe, grant the prayers. So do pray for your friends, for your family members. So psychotherapy helps people with a mental disorder to understand their behaviors, emotions, and ideas that have contributed to her illness, to his illness, and learn how to modify them, because not everybody have the capacity or the skills that they've learned throughout their lives that can help, that can be helpful for them. If they come from a broken family, if they come from a risky, vulnerable personality, if they have a hereditary from the family on mental illness, then it's hard to already have the insight or psychological understanding that it may be because of your thoughts, it may be because of the way you perceive that situation. So we need to teach them things such as parenting skills. I need to teach young parents, even old parents, even experienced parents, because they're not able to learn on their own. Yeah, maybe they've not got good models from their parents. So some of the things we have to teach. Understand and identify the life problems or events like a major illness, a death in the family, divorce that contributed to his or her illness, and help her or him understand which aspects of the problems he may be able to solve or improve. Like trying to put in the jigsaw puzzle for them to be able to see that these are the contributing factors that led to your illness, and we understand why the problems is becomes why you're having this problem because of this and this demand put on you, and you're not able to have the adequate resources to deal with it, and we want to help you, we want to support you. Yeah, so psychotherapy is about helping clients with a long-term skills for them to be able to help themselves without us being there anymore. So, yeah? So medication helps as well to stabilize them. So we work hand in hand with psychiatrists, medical officers, for them to be able to stabilize the person with medication if they need to be. If they don't need to have medication, then they, for example, mild anxiety or mild depression, then they can just come to us for psychotherapy. Okay, so we help them to regain a sense of control and pleasure in life, get them to be more enjoying life, and we learn and teach them healthy coping techniques and also problem solving skills. Okay, there are mental health professionals are psychologists, including counseling psychologists, clinical psychologists, health psychologists, and there's the numbers in Malaysia per 100,000 is one every 100,000, 1.03. For psychiatrists, it's a bit more, 1.05 per 100,000 people. However, clinical psychologists is, I just put here the qualifications for clinical psychologists, but the number here, 1 per 100,000 includes other psychologists professionals such as counseling psychologists and health psychologists, because clinical psychologists are very few, increasing but very, very few, still about 0.5, 0.6 per 100,000 people, not even one. Yeah. So the qualification is that one would need to have a master's in clinical psychology to be able to practice in Malaysia. A PhD would be better still. And we can make diagnosis, but our differences is that for psychiatrists, they need to have a degree in medicine and they need to do a master's in psychiatry. We don't have a degree in medicine. Our degree would be in psychology or a postgraduate diploma in psychology. Yeah, it needs to. We need to have a foundation of psychology first. So our expertise is psychological assessment and psychotherapy. We make assessment, diagnosis, and also psychotherapy. But in Malaysia, there's no act to protect us from, for example, making mistakes in diagnosis and we'll get sued, whatnot. So we don't make diagnosis. Usually the psychiatrist would make a diagnosis, but we're equipped to make a diagnosis. We've been taught to do so. So the psychiatrist, their major role is giving medication, but their minor role is psychotherapy. So they are equipped with psychotherapy skills. Okay, but usually they would give medication first and then follow up with psychotherapy sessions. Okay, so this is cited from WHO Mental Health Atlas. Counselors, what they do is that they help with mild disorders, not disorders, mild issues. Yeah, not yet come to a point when it is a mental disorder just yet. So they help with everyday problems, but when they see that the patient has not been able to improve, then they would refer to us if it has become a mental disorder. Yeah, but they help with the mild issues to prevent them from mental illnesses, and also to help with improving mental well-being. Psychotherapy theories as a roadmap. Psychologists would generally draw one or more theories of psychotherapy. A theory of psychotherapy acts as a roadmap for psychologists. It guides them through the process of understanding clients and their problems and developing solutions. Why we call psychologists call patients as clients, though I still use hand in hand clients and patients, is because patients would usually be someone whom we give medication to, or someone that is treated as patients. Macam a client is like on par. For psychologists, we call them clients because they are on the same level as us. Not patient is like a doctor is here and a patient is here. It's like a different level, a connotation of different level. So we call them clients. We're taught to call them clients, but in the clinic, I would, with the other doctors and everyone, just call them pesakit macam tu kan. Kalau tidak kita panggil client. So we need to have theories as to guide us as to which is a more evidence-based psychotherapy, which has been proven to be effective for this type of illness. Yeah, so we need to be equipped with these theories. So one of the therapies that we do to our clients, that we engage with our clients, is psychoanalysis and psychodynamic. This approach focuses on changing problematic behavior, feelings, and thoughts by discovering the unconscious meanings and motivations. It's characterized by a close working relationship, and patients learn about themselves by exploring their interactions in the therapeutic relationship. So it's identified with Sigmund Freud and has been extended and modified since its early formulations. I don't do this, but psychiatrists do it, and many psychologists who are trained in the US do this. I have quite some issues with it because the Sigmund Freud's theories are not Islamic, they're not even scientific, but I don't know why it's still in the textbook and being taught. But nevertheless, the late Professor Dr. Malik Badri, who is a clinical psychologist, father of Muslim clinical psychologist that we call him, just recently passed away last year, taught us about criticisms about how non-Islamic Sigmund Freud's theories are, but there have been scientific evidence with his ideas later on that have been developed by other psychologists, his daughter, but not his, but the criticisms come from his original idea about seeing objects as sexual objects, seeing human beings as in a sexual perspective, whatnot. So these are all not Islamic at all and not scientific. So behavioral therapy, this approach actually takes on a learner's role in developing both normal and abnormal behavior, whereby Pavlov came up with classical conditioning. I think you've all learned this in year one, okay? When the dog learns to drool when it heard the dinner bell, because it shows that when the bell rang, then the dinner will come. So it similarly is related to how we are able to do sensitization and also desensitization with our clients, giving also reinforcements. It teaches us about reinforcements, that when something is coupled with a reward, then it's more likely that they will be doing something when we give the stimulation itself. So it helps, for example, with a phobia, with repeated exposure to whatever it is that causes anxiety. So we would desensitize the patient with a repeated exposure, to go up the staircase and go to the higher floor when they have height anxiety. So when it's when they get desensitized with it, when they're already used, their brain gets used to it, then they get less anxious, and they'll be able to recover. And then comes in operant conditioning, which helps with rewards and punishment to shape people's behavior. And these variations have developed with cognitive behavioral therapy, which is combining both cognitive therapy and also behavioral therapy to help with patients. So cognitive is basically emphasize on what people think rather than what they do. Behavior is what they do. Kalau cognitive ni, they believe that dysfunctional thinking leads to dysfunctional behavior and emotions. So by changing people's thoughts, people would change the way they do things and the way they feel about things. So CBT has been proven to be effective in depression, anxiety, panic attacks, phobia, OCD, PTSD, and eating disorders. I would do a lot of humanistic therapy. I do CBT as well, but usually I would do this, and this, behavior, CBT, humanistic, acceptance commitment therapy, dialectical behavior therapy, a bit of this and this and this, tailored according to the disorder or the presentation of the client. So it doesn't have to be, overseas, it would be like, you do CBT from beginning to end. There are just CBT therapies, humanistic therapies, psychoanalysis therapies, like that, because there are many therapies. But in Malaysia, because there are so few, there's only 2 of us in Pahang, one in HTA and another one me. So we could just do whatever. I mean, whatever that we have, whatever little knowledge that we have, we just do what we can. So I just do eclectic. I mean, I'm not a licensed therapist for any of the psychotherapy, because my PhD was in suicide in Japan, but because I could not speak Japanese, and therefore I did not do my clinical work there. It's just gathering data and also analyzing and doing a prospective study. And therefore I'm not a licensed therapist in anything, not an expert. So I just do whatever I can with the reading ups and going to workshops and whatnots to help me. So what is humanistic therapy? Its approach is on people's capacity to make rational choices and develop maximum potential. It has respect for the human potentials. It's based on client-centered therapy, whereby therapists help clients to change by emphasizing their concern, care, and interest, meaning the client actually choose whatever topics they want to talk about, and the therapist will act on those. So Gestalt therapy is another thing. It's not under humanistic, but I think it's also related to it. The importance of being aware of the here and now, accepting responsibility for themselves. Existential therapy, it focuses on free will, self-determination, and a search for meaning. Yeah, it's very related to humanistic therapy as well, I think, because that's why I put it here. Oh yeah, it's got 3 types of humanistic therapy. All right, so it's under humanistic therapy. I should know that. Many therapists don't tie themselves to any one approach. Instead, they blend elements from different approaches, and it's called eclectic therapies I talked about. Some of the more recent psychotherapy, acceptance and commitment, dialectical, interpersonal, eye movement desensitization and processing, EMDP, and many others that I've not really mentioned, but I do practice. But you'll learn more of this as you go along. So there are many forms of therapy as well. There are individual therapy, there are family therapy if they need to, if the problem is about family, then we call them family members with the permission of the patient. If the patient does not permit, we won't tell anyone. We just don't discuss their client, their problems with their lecturers, with their parents. We don't tell. It's very confidential. Okay, if you need to have a report, you need to come and get the and apply for the medical report, and that goes through a very long process. So inshallah, we keep your identity closely to ourselves. There's group and also couple therapy. Psychotherapy for PTSD. A study has found from 72 treatment conditions involving 32 PTSD trials with number of nearly 3,000 patients, found that significance found in the period from pre-treatment to long-term follow-up, but not post-treatment to LTFU. LTFU is long-term follow-up. This meta-analysis studied about the effects of psychotherapy for PTSD with long-term follow-ups of at least 6 months. Yeah, so it found that from the effectiveness takes place from pre-treatment to long-term follow-up, but not post-treatment to long-term follow-up, not after the long-term follow-up, the treatment that they take maybe after 6 months, it is not, the effects is not anymore there. So all active interventions demonstrated long-term efficacy. So still, it shows that there is a long-term efficacy of follow-up of psychotherapy, that at least for 6 months after the psychotherapy. Group psychotherapy for OCD among 800 patients showed that effect size estimates suggest that group psychotherapy is highly efficacious in improving OCD symptoms in comparison to waitlist control groups. However, no significant difference was found between group psychotherapy and active control groups, such as individual psychotherapy, pharmacotherapy, or common factor control groups, meaning that the value of group therapy is as effective as is as effective as psychotherapy, pharmacotherapy, meaning with medication given to the patient and with psychotherapy as well. There is no significant difference between we couldn't find that group therapy was better able to help than individual psychotherapy, but it helps with waitlist control groups, the ones who have not received any psychotherapy. The ones who have received group psychotherapy is more effective, of course. The value of group therapy as an effective treatment for patients suffering from OCD may have been found. For social anxiety disorder, it has been found that also group psychotherapy has been an effective treatment equivalent to other treatment formats. For this study, they found among 2,000 patients that cognitive behavioral group therapy, CBT done in group, have been found to have medium to large positive effects from control group. Form, no difference appeared in comparison between group and individual or pharmacotherapy. Therefore, it's considered effective, still effective. Meaning it is as effective as individual, and the group therapy is as effective as individual. So why don't we go for groups? Because groups will take in small number of resources, because we do in one go. Yeah, so it is very effective that we do it in group, that we collect all our patients and put in groups. Yeah, I used to do that, but I don't know why I have not been doing that for quite some time. I think it's because the pandemic thing. Before that, I used to put in quite a few patients together, like panic disorder, and then I do CBT to them. Yeah, that reminds me, I have not been doing it for long. Intensive and brief psychodynamic in MDD patients. Can't see it. Whatever this IBPP is a treatment. Brief psychodynamic psychotherapy. Intensive appears to be valuable adjunct in the treatment of depressed patients. Yeah, sorry for the many texts. It has found to be as effective in reducing depression and severity. For psychotherapy to treat mild and moderate depression, it has been found that there are no large difference in efficacy between major psychotherapies for mild to moderate depression. Yeah. So this study shows that psychotherapy for mild and moderate depression is actually similar. It doesn't have to differ. Not doesn't have to differ. Meaning psychotherapy is found effective with both mild and moderate depression. Okay, so having said that, those with severe still need to have pharmacotherapy. They need to be given medication first, stabilized, and then given for psychotherapy. Tapi for mild and moderate depression, psychotherapy has been proven to be just as effective for both of these. Okay. Similarly, for postpartum depression, interpersonal psychotherapy has been found to reduce depressive symptoms and improve social adjustment, and represents an alternative to pharmacotherapy, particularly for women who are breastfeeding. So there have been many studies as well saying that for those with postpartum cannot take medication, for those with mild and moderate depression, even without medication, psychotherapy is just as effective. Yeah, like this. Pharmacotherapy was significantly more efficacious than psychotherapy for in dysthymia, in persistent depressive disorder, and psychotherapy was significantly more efficacious than pharmacotherapy in OCD. For dysthymia, pharmacotherapy is more effective than psychotherapy, but for OCD, the study has found that psychotherapy is more effective. Okay. Furthermore, pharmacotherapy was significantly more effective than non-directive counseling. And psychotherapy was significantly more effective with how do I say this? Tricyclic antidepressants. So this study wanted to find out whether in different disorders there have been any different efficacy between psychotherapy and medication, because many of our clients that we see refuse to take medication. So we try out with psychotherapy first, but usually if many have been able to improve, but some will still need medication. So I would refer them back. I would talk back to his doctor and tell them that they really can't do without medication. So we need to help them. So we still try to get them to take, but again, it depends on the clients. If they don't want to take, we can't force them. But the effectiveness is different lah with and without lah. CBT in Malaysia, The best group was CBT in combination with fluvoxamine. This indicates that the best way to treat panic is to combine drug treatment and psychological treatment. Yeah, so for panic, it's shown that with both is better than just one. Yeah. Yeah. Less research on efficacy of psychotherapy in Malaysia. Results indicate that still psychotherapy research is weak and fragmented. Major limitations on the studies, and so we can't really say in Malaysia on how effective this has been in the science, in the literature review. Not many research have been done as well. Research at the University of Arizona and Bern suggests that patient coping style and reactance levels may be predictors of different rates of response to different psychotherapy procedures. Yeah, different predictors towards how psychotherapy works according to how they react and according to how they cope. So again, it's different from person to person. Yeah? Even medication reacts differently to people. Similarly with psychotherapy as well. So defense mechanism is already. I'm going to the next chapter, the next topic, but I guess we'll take a break here. I'm just going to go down for a while, see my daughter, because I'm listening, hearing her voice. Or shall we? What do you think? Do we have any questions in the chat? Or shall we continue for a bit until 9:30?
Sure, can.
We can continue?
Yes.
Yes, sure, doctor.
Okay, okay. Okay, let's just continue and take a break at 9:30. Yeah. Defense mechanisms is from Sigmund Freud. He noted a number of ego defenses, which he refers throughout his written works. And his daughter, Anna, developed these ideas and elaborated on them. Many psychoanalysts have also added further types of ego defenses. So we would go into these defense mechanisms. Things such as defense mechanisms, and some others of Sigmund Freud have been noted to be effective, have been noted to be close to reality through the scientific studies. So there are many, there are some contributions from Sigmund Freud. I'm not saying that not at all. It's just that his original idea have been criticized by Muslim psychologists. Okay? But we do study a lot on his ideas. Yeah? So one of them is defense mechanisms. These are psychological strategies that have been unconsciously used to protect a person from anxiety. It arises from unacceptable thoughts and feelings. Yeah? So we use these strategies that we are not even aware of when we're not comfortable with the anxiety that we have, the nervousness that we have. So when we don't want that unpleasant feeling to arise, we use defense mechanisms to help us out. Yeah. So one of which is denial. I think all of us use denial once or more time in our lives. It's a refusal to accept reality, thus blocking external events from awareness. Yeah? Many people use denial in their everyday lives to avoid dealing with painful feelings or areas of their life they don't wish to admit. For example, smokers refuse to accept that smoking is not good. It's all right. My grandparent didn't die of smoking. Why would I bother? deny that because they want to smoke still. A husband may refuse to recognize obvious signs of wife's infidelity, although there have been many evidences, but he still refused it because of his denial, not wanting to accept reality. Yeah? A student may refuse to recognize their obvious lack of preparedness for an exam. Yeah, they just think that it's okay. I can do it well. It's all right. They don't want to accept that they're actually not prepared. Okay, so that's denial. Repression is when you repress an unconscious trauma that you may have had because it's so threatening, because it's so painful. So you tend to repress it from coming to consciousness. Yeah, these are thoughts that will result in feelings of guilt from the superego. So forcing disturbing wishes, ideas, or memories into the unconscious will still create anxiety. Yeah, however, you don't want to take it into consciousness. Yeah, so repressed memories may appear through subconscious means and in altered forms such as dreams or slips of the tongue, called also Freudian slips. Sometimes when it's repressed, but sometimes it manifests from the slip of a tongue. Like you say something and then you say, no, I don't mean that. But actually it comes from something that you've repressed. For example, memories of sexual abuse, or something that you want to keep in, something bad that you observe, something that you don't want to keep coming. Yeah, so you repress it inside yourself. Projection is an individual attributes towards unwanted thoughts, feelings, and motives into another person. Thoughts that most commonly projected onto another are the ones that would cause guilt, such as aggression and sexual fantasies or thoughts. For instance, you project when your superego tells you that such hatred is unacceptable, you can solve the problem by believing that they hate you. Yeah, you hate a person, but because you know that you shouldn't hate, that Muslims shouldn't hate people, so you projected that they hate you in return. So you kind of believe that actually I like them, but it's because they don't like me. That's because I don't like them. But yeah, you kind of like try unconsciously project your own emotions to the other person. Yeah, so that's projection. Displacement is when you redirect an impulse, usually aggression, onto a powerless substitute target. The target can be a person or an object that can serve as a symbolic destitute. For example, when you are frustrated by your superiors, but you can't beat them up. So when you go home, you'd be very angry at your children. You would displace your anger at the workplace, at home. Yeah, so that's a displacement. Someone who feels uncomfortable with their sexual desire for a real person may substitute a fetish. Boleh juga macam tu. So displace your anger, your aggression into something else, to a pet, to a dog, to a cat, to a dog or something. But actually you would want to kick a person. Regression is when you regress to an earlier stage of development, usually in response to a stressful situation. It's when you become a child again. It's when a child began to suck their thumb again, wet the bed, when they need to spend some time in the hospital. Teenagers may giggle uncontrollably when introduced into a social situation involving the opposite sex. When they're stressed out, sometimes they regress back to their young self. Yeah, so that's regression. Sublimation is when it's similar to displacement. It's when we manage to displace unacceptable emotions into behaviors which are constructive and socially acceptable rather than destructive activities. Displacement tadi tu yang dia tu displacement ke apa nama dia? Yang ni macam benda yang negatif, things that are negative like aggression. Tapi sublimation tu, they do it, they displace it, but it's into something acceptable. They, for example, many great artists and musicians have unhappy lives, but they use the medium of art to express themselves. Yeah, they use the medium of art to be able to let go of their sorrow. They use music to be able to express their sadness. So they use positive things to displace their negative feelings. Yeah, so that's sublimation. For example, someone who's aggressive, they go into sports because they don't want to be hurting other people. So they go into sports, which takes away their energy. So it's something very healthy lah kan. So they're able to do something else. So that's one defense mechanism that's healthy. A rationalization is about distorting facts to make an event less threatening. We do it often on a fairly conscious level to provide ourselves with excuses. Macam kita kata, adalah hikmahnya tu, benda tu jadi kan. Kita rationalize tau. Kita macam tell ourselves that well, actually it's anxiety, but we want to reduce the anxiety. So we tell ourselves that there's a silver lining behind this event. It's okay. There must be something that happened. And it's right, when we have faith, we believe in that kan. Tapi benda tu untuk nak Freud kata is a defense mechanism that we use to get us off anxiety, to get rid of anxiety. Yeah. Reaction formation is when people go beyond denial and behaves in an opposite way to which he or he feels. It's when conscious behavior are adopted to overcompensate for the anxiety a person would feel regarding their socially unacceptable unconscious thoughts or emotions. It's usually marked by exaggerated behavior such as showiness or compulsiveness. Macam an example of reaction formation, kalau dalam Freud, there is the Oedipus hatred. Dia kata macam parent ni selalunya favorite dia adalah the opposite sex. So the father would be close to the daughter and the mother would be close to the son. So the mother and the daughter are actually hating each other. Yeah? So an example of reaction formation ni dia kata, dutiful daughter who loves her mother is reacting to her Oedipus hatred of her mother. Dia kata sebenarnya this daughter ni hated her mother so much, but so this is actually reaction formation. Hated, tapi dia jadi dutiful pula. Dia macam menjadi orang yang terbalik dengan diri dia sebenar. And it goes beyond denial because they behave in an opposite way to which they actually think or feel. Macam mana dia nak tahu? I don't know. I mean, how would you able to? But it says that when one is very anxious, this reaction formation, one behaves in a totally opposite way. For example, one may have killed a person in a langgar lari, hit and kill, kill and run incident, and then when they grow up, maybe they were involved in that when they were a teenager. So when they grow up, they become a police traffic macam tu. So they behave in an opposite way to actually complement the guilt that they have or the anxiety that they have, that they've killed someone and ran away, and so they become a police traffic man just to protect their guilt, protect the blame that they have, not the blame, protect the the wrongdoing that they have. Yeah, so that's reaction formation. It's very drastic behavior that they do to cover up their own inner feeling. So that's it. There are actually many more defense mechanisms, but I would just go through that. These few. There are mature and immature ones as well. Mature is the healthy ones and immature is the unhealthy ones, if I'm not mistaken. But I think there's no need to go further. When you're in year 5, maybe they need to remember those, to understand those. For year 4, I think you just need to understand what each means, yeah, and give an example as well. So that's it. All right. So if you have any questions to ask. Thank you very much for your attention. Stop sharing. Have you got any questions? You can ask by everyone. Please put in your attendance here. Do ask questions if you do have. We have until 9:30, inshallah. Regarding psychotherapy, regarding defense mechanisms. Have any questions? Are you all awake?
Wait, doctor.
You have a question, Amir?
No, doctor.
No.
Assalamualaikum, Doctor.
Waalaikumsalam.
I want to ask a question. What is difference between repression and suppression? Is it the same?
Thank you, Ain. Repress and suppress, I think these are two different defense mechanisms. Can we all search? I'm not sure if I would give the right answer. Let's take a few minutes just to search the difference. You can all search as well. I think it's about the level of the deep insight level that they have.
Isn't regression when the person back to child behavior?
Again?
The regression is when the person who experienced the stress or traumatic events, then he becomes somewhat back to childhood behavior, childish behavior. Isn't that?
Okay. Yeah. The difference is unconscious and conscious blocking. Repression is when you automatically, not knowing, unconsciously repress whatever trauma, like you said, the trauma that you have had in the past. You tak ingat pun, you tak perasan pun, bukan tak ingat, you tak perasan pun sebenarnya ada benda tu sehingga ada trigger yang menyebabkan you ingat balik. Probably long time ago when you were a very small child. Tapi suppress tu, you do it consciously. You suppress it. You voluntarily do it because you don't want it to be out in the consciousness. Tapi repression tu macam benda yang unconscious, benda yang involuntary. Ya, macam tu. Terbalik. Suppress yang tak perasan. Repress yang suppress yang perasan, yang voluntary. Tapi repress tu involuntary, yang benda trauma. Benda yang trauma dan you tak perasan pun sebenarnya you duduk simpan. Macam tu. Nampak macam tu lah, sebab kalau repress, unconscious blocking of unpleasant emotion, impulses, memories, thoughts from your conscious mind. Ya, unconscious blocking. Tapi kalau suppress, dia individuals cope with distressing mental content by voluntarily making efforts to put them out of conscious awareness. Jadi dua benda berbeza. Kalau suppress tu dia voluntarily, kalau repress tu unconscious, dia tak perasan pun. Okay?
Thank you, Doctor.
You're welcome. Seems like you have a question, Aziz. Thinking deep.
Doktor, saya nak tanya boleh?
Boleh.
Is it normal if you don't remember your childhood?
Until what age?
I don't know. Maybe like sekolah rendah ke?
I think it differs from person to person. For some people, they can remember as early as 3, 4. They can remember very vivid memories of when they were young. For some others, even primary school pun dia ingat certain moments saja. Macam very, itu pun tak vivid. Itu pun macam unclear. Macam very like things that trigger emotions, baru dia ingat. So I think it differs. It doesn't have to be something that you don't want to remember or something very painful. It's just different abilities. Yeah. So I think it's normal. Yeah.
Okay, thank you, Doctor.
Welcome.
Doctor, for counseling, just now you've mentioned it's a pre-mental state disorder. So it's before a person actually or a patient actually go into a mental state. Do they use also psychotherapy and pharmacotherapy, or they just use some kind of other terms or other methods?
Yeah, counseling, they just use counseling. Just psychologists, we don't give any medication. We're not trained to give medication because we're not from a medical background. So counselors, clinical psychologists, we don't give any medication. The medication are given by the doctors. Okay, so that's one. So for the people who go for counseling, they're given counseling skills. They're given problem solving skills, coping mechanisms, how to sleep well, how to take care of your diet, things such as this. But these are people with mild problems, yeah, milder issues, not yet gone into disrupting functioning of their lives, because it becomes mental disorder when they're not able to get out of a problem, and it's affecting their personal lives. It's hard for them to do their personal routine, going up, doing salat, going to school, eating, even getting up in the day they need to force themselves up. Okay? Or it involves social functioning. They're not anymore socializing with friends as they used to be. Family members see them as not as their old self. People see them differently. And they also don't want to see people. And then work or study functioning. They're not able to put focus, work well, be effective as they used to be. So when these have been affected, then and it meets the criteria of DSM, so it becomes a mental disorder. So then only the medication comes in by the doctors, and also psychotherapy comes in. So the counseling psychologists would usually just do counseling. It's not called psychotherapy. Psychotherapy is given by those with clinical background. It's for those with mental disorders. Yeah. So but in Malaysia, there's a fine line lah. Very fine line, sebab tak banyak. There are not so many clinical psychologists just yet, and therefore many counseling psychologists also go for short psychotherapy courses. So there also some of them are equipped with CBT. Only that because there is also no health act that protect us from mistakes. That's why people are taking up psychotherapist's job. But actually overseas is only done by those with licensing of clinical psychology license, not done by counseling, because they can sue, because it involves lives, yeah, because it's already become a mental disorder with many risks involved. But because there's no act, so any ustads can also, who have gone to a probably 2-day workshop, say they are a licensed CBT. So it's very dangerous. It's very dangerous to do this. And we are alarmed by the fact that JAKIM officers recently been trained, I think 3 or 4 days. And our minister in the Prime Minister's department says that there are now therapists for mental disorders, for major depressive patients. And we're like, no way, very risky. There's no line in our country just yet, but we're fighting for it. Please make prayers that it will come out soon. So now it's like everyone can say that they are therapists, even one with a psychology degree, but actually a psychology degree does not make one a psychologist. It's just theories. One must have a master's degree for them to become a psychologist, to actually see clients, because it involves problems. And if they say something wrong, and if the patient or client follows whatever they say, they can actually sue you. So banyak risk involved lah. Thanks for the question.
Doctor, so basically, can we say that clinical psychologists can do counseling and psychotherapy, but counseling psychologists can do only counseling?
Yeah, true. We are taught about counseling as well, but we don't call it counseling. We call it psychotherapy. But we are taught to to meet milder. I mean, counseling. How do I say? Actually, sometimes there are some difference lah. A lot of difference between counseling and psychotherapy, because counseling it doesn't involve skills that cater to mental disorders. So usually, if people would come for even mild issues, I would usually choose some psychotherapy, because we only have like one topic on counseling, and the others are already gone into what psychotherapy best suits this, found more effective for this illness. And so therefore it is a part of it. It's very much correlated, but it's not just counseling. It's also, it involves a lot of psychotherapy as well. Yeah, if that helps. I don't know how to differentiate between the two, if you ask me, because it's part and parcel of it as well. Yeah, so okay. I think someone wanted to ask. Aziz wanted to ask.
Yes, I have a question. One is, when we do psychotherapy, basically, for example, we encounter a person who have somewhat personality disorder, like sociopath or narcissistic disorder or histrionic, or any part of personality that somehow he had been living in that way for most of his lifetime, you know, like, so how do we change? Because what they consider normal is actually abnormal, so we need to change the perceptions, the cognitive, everything about them. So how do we approach that kind of person? And because we need to, you know, a certain level of personal things that on that person that we need to dig in and change. There's a lot of work. I just want to ask on how the process. That's the first question. Second question is rationalization. What is the difference between rationalization and reframing of events, or changing the narrative? Or is that also one of defense mechanisms? You know, reframe and rationalize. That's all.
First, I'll answer your second question first. So rationalization, I think reframing also is also can be a part of rationalization as well, if it involves making rationals or justifying something that you did because of something else. Yeah, okay, terima kasih. Tutup pintu ya, pelan-pelan. For example, like you reframe that that something happened because, for example, like you broke up over a relationship with a girlfriend, and you've reframed it as such that, okay, so this is a hikmah, and there is a hikmah underlying it. I have learned about this characteristic of a person whom I am not able to tolerate. Okay, so you reframe it as such. Kalau rationalization pun boleh juga kan, dia boleh jadi macam tu juga kan, lebih kurang sama lah, betul tak? Tapi nama je lain. Tapi reframing ni it's changing or modifying your interpretation as such that it's helpful for you. I think it can be under rationalization as well, but rationalization is more like you intellectualize, you find some excuse. They say it's a defense mechanism. I think it's another way of putting it lah. Dia kata defense mechanism sebab dia nak kurangkan anxiety, tapi pada masa yang sama it's mature defense mechanism because it helps you in a healthy way. So it's not necessarily negative. Yeah. So I think it's very much related, but not the same, but related. Your early question about personality disorders, yang ni antara paling susah dan not a lot of evidence based, especially for psychotherapy. Even medication does not help with personality disorders, but psychotherapy helps. But there's still many not many very strong data that can say that this type of psychotherapy really helps with this. Dia tak ada macam tu, especially borderline lah. If I've gone through more borderline cases than the others. But having said that, yes, because it's been part and parcel of their lives, so it doesn't come with just a simple, just a few sessions. So it has to go through years of psychotherapy, and very much important is an insight or awareness that the person has a problem, has abnormal problem. They're wanting to change. When they want to change, when they see that their thinking is abnormal, the way they do things is abnormal, the way they view life is abnormal, then it becomes easier. But still, it takes years and years, many years. And it's not easy. And many times you have to involve family members, people who are close to them as well, to help them. There have been successful cases, but still it's not like none at all, not like you're recovered 100%. No, it's gradual, and it needs a lot of insight and a lot of social support in the patient's lives. But at least it gives them the ability to be more conscious over what they do, the ability to take a break from spontaneously or impulsively doing things and thinking about what other people would perceive this to be. What are the ways am I going to do this that can be more helpful? They can actually be more conscious of it rather than not being just doing it whatever way that they wish, and it will eventually distance people away from them, make them hard to work, can't function. Macam tu. Aziz, I hope that helps.
Yes, I have a practical questions. Usually those people yang di psychotherapy, is it like referred case from psychiatric and then good psychotherapists or clinical psychologists or those yang counseling session lah. But what are is it like someone tell them that you behave quite abnormal and then they go to seek for psychological advice, or
what's the process?
I mean what caused them to go and seek for
help,
the session, seek for
depends. Banyak orang datang, bukan banyak lah, depends really, tak boleh cakap banyak juga. Tapi orang yang datang, those who come to us with the insight that they have a problem. They know they have a problem. It's not themselves anymore. They feel very hard to continue their work. They feel very hard to feel the same way towards their family members. They feel that they want to hurt other people. They're already holding a knife to hurt themselves or other people. At that stage, they feel that they need to get help. And then they come for help. There are also cases, especially when it's teenagers or children, when parents come and take their children for help, and we help them. But adults, usually they would be able to see that there's something wrong with them. But again, personality disorders, kalau macam narcissism, antisocial, hampir-hampir tak ada lah datang kat kita. Cuma kita tahu daripada family member yang dah jadi depressed. So family members come and they tell about their mother I think my mother is a narcissistic, and tells about depression dia sebab datang daripada mak yang macam gini. So kita ajak dia datang sebagai family member, bukan sebagai ni, and then we assess them and then we offer help. But kalau narcissistic ni memang susah lah. Dia nak berubah macam mana, dia almost I have not come to any success, and I have not seen any success in my yet short period of practice. But their children are depressed, gila-gila punya depression. Oh, bukan children je, spouse. So we treat them as our patients, and it's not just one, it's the whole family. One by one we treat them. Very sad. So nak katanya lain-lain juga, tapi banyak juga yang datang selepas, after they've gone through Ustaz, after they've gone through spiritual therapy that have not been helpful, then they come in after a few years, or after the depression dia dah teruk dah. So kita ambil masa sikit lah untuk nak bantu. Yeah. Kalau dia datang awal, there are people who have come earlier on, especially those who are educated. Then they're more likely to recover just after taking medication, and after like 3 psychotherapy sessions, memang boleh baik lah. Banyak je yang baik macam tu yang kita nampak. Tapi after taking medication lah, of course. For them to be taking medication and come to me, that would take 3 sessions, 4 sessions macam tu dengan doktor. Lepas tu dia datang, lepas tu dia refer. Usually lah, tapi kalau tak teruk sangat, mungkin ambil masa lama sikit, especially pandemic ni lama sikit. Okay, Muhammad Haris asked, how about repression and dissociation? Like dissociative amnesia. Yang ni dah macam, yang ni dah mental disorder, Haris. So it's not anymore a mental defense mechanism. So dia dah lain dah. Kalau repress tu, dia just macam tak. Dia boleh juga ganggu. It can disturb your functioning, and it can become that as well. It can lead to a mental disorder as well, but it's just a description that one may be doing this so that it can describe the process that we humans go through when they wanted to fend off their own anxiety from disturbing their lives. But it can also become a more chronic, like dissociative amnesia. Yeah. Repress ni tadi yang involuntary kan, mungkin ada they're not conscious of it, but usually people around them would be conscious of it, would be referring them for help lah. Okay, it's not the same, it's different. Dissociation is different. All right, so it's 9:30. We'll see you again. I'll see you again at 10:30. Boleh untuk seminar. I'm just gonna. I think my daughter tidur, tak lah. I'll just prepare to send her to school. And then I'll see you again kan dekat petang kan for your representations, betul tak? Oh okay, for my group only. For other groups tak? Betul tak petang ni kan? Ke bila? Yeah. Alright. See you later. Assalamualaikum. Let's end our lecture with tasbih kifayah and suratul asr. Subhanakallahumma bihamdik asyhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Bismillahirrahmanirrahim. Wal 'asr innal insana lafi khusr illa alladziina aamanu wa 'amilus shalihat wa tawassaw bil haqq wa tawassaw. Assalamualaikum.
Salam. Thank you, Doktor.
Thank you, Doctor.